Good morning, everybody. I'm Hugo Sachs. I'm actually the chairman of the ADRF board, and it gives me great pleasure to welcome you all here today. Research is a fundamental essential, and I note that we have a number of our sponsors, those that have provided funding over the years here, and we thank you very much, A, for being here and your contributions up to date, and we hope that that keeps on going for the future. We have a panel today, which is a first for the ADRF, which will extol the virtues of what's been going on over more recent years in research, and there'll be a bit of a Q&A, I think, at the end of it. So thank you once again, and I'll now hand over to our panel, and thanking them, obviously, in the first place for their work, Munira particularly, and Rachel, for the work that they've done in getting this all together. Thank you.
Thanks. Okay, I'm Carolyn Dean. I'm your MC for the day. I ask you all to put your headphones on because that means that the panelists and I do not have to project our voices for the next hour, so appreciate that. Okay, this is the first ADRF event, not just breakfast. And thank you to Munira for being the brainchild of this panel, and for Deb and the ADRF team for putting this event together. The ADIA, also we need to thank for hosting us, putting on the room, and their ongoing support. So thank you all. And thank you for those of you that are interested in research, interested in the future of the dental profession and what this means for us all. So I'd like to start by asking you all, the panelists, to briefly introduce yourself and explain why you're here and why research has made you get up early on this rainy morning. So, starting with Deb.
This is going to sound now very much like the Middle of England show. We come from we come from villages of only a few miles away from each other, so we're Blues now. That's people like us. This is amazing. This is absolutely amazing that people have got up and attended this, and kudos to Munira for pulling things together so beautifully. My name's Deb Cockrell. Up until recently, I was chair of the Research Advisory Committee, and we made a strategic move to try and optimise research funding opportunities to groups and for collaborative research, and trying to go also beyond the field of dentistry and work with other in an interdisciplinary context. So we've made a bit of a shift in terms of our funding model. Munira is now the chair of the Research Advisory Committee, and I've moved on to marketing and fundraising. So I'm going to make sure I get everybody's name badges before you go. You won't be allowed to leave. Thank you.
Thanks, Deb.
My name is Matt Hopcraft. I'm a public health academic at the Melbourne Dental School. I'll be enforcing the other door on the exit just to help Deb collect all of those names on the way out as well. I've been involved in dental research since very early on in my dental career, and ADRF was sort of instrumental in helping me start some of the research that I did, and we'll talk about that, I think, as the panel goes on. I think clearly research is really important for our profession. We don't have a dental profession without the research that underpins it. We talk about evidence-based practice, but we also need dental academics to train the future dental workforce. And without dental academics, we don't have a future workforce. So research funding is a really instrumental part of that. And I think that that's something that we're really going to talk about a lot today. And so the opportunity to come out here and talk about how important ADRF is, how important dental research funding is, was the thing that got me out of bed this morning.
My name is Munira Xaymardan. I'm the new chairwoman for the Research Advisory Committee, succeeding Deb. My day job is academic in the Sydney University, the Faculty of Medicine and Health. I have been teaching and researching for past 20 years. I sit in the intersection of systemic medicine and oral health, research and teaching. So I want to bring this multidisciplinary collaboration spirit and networks to the Dental Research Foundation. As future evolves, we will need more of a collaboration with medicine, with bioengineering and AI, robotics, and so pursue more of a multidisciplinary research activities. So thank you all for supporting today's event. So the panel has made a great effort to make this event visible. And we want to make it a success story. Thank you.
Hello, everyone. Firstly, thank you for the opportunity, and thank you all for coming. My name is Ajesh George. I wear two hats. My first hat is I'm a professor of interprofessional oral health at Western Sydney University. I'm also the co-founder and director of the Australian Centre for Integration of Oral Health, which is a national centre that was established more than 10 years ago with formal partnerships with public oral health services, state governments, and professional organizations, trying to drive a paradigm shift in oral health care. So I've been involved in oral health research for more than 18 years, and I've seen firsthand how it can shape policy, practice, and improve patient care. So I'm here to share some of my thoughts and to tell you that I wouldn't be where I am here without research, and nor would the centre have been established. So thank you.
Amazing, thank you. So we're going to talk now about research and specifically what it's meant to you all in your own areas. So Ajesh, I want to carry on the conversation with you, and can you explain pre-seed funding, what it's meant for you, where you would be without research, and what it's meant to have the research in your area?
I think for me it all stemmed from the fact that we now know that oral health has a strong link with systemic diseases, and the issue has been that there's been a lack of awareness in the community about the importance of it, and every day the evidence is growing. We know that poor health is linked with various conditions. It has direct links with cardiovascular disease and diabetes. So I've been able to initiate a program of research where I've been able to try and drive that awareness building and change, and trying to bring in the awareness from the broader health workforce to play a key role. And so if it wasn't for research, I wouldn't have been able to start a program of research that eventually became this national center to drive this. I'm not going to dive into the oral systemic diseases. Do you want me to talk about that? Yeah? Okay.
Yes.
Yeah, because I think every day there's more and more research showing the strong evidence, and in some conditions like diabetes and chronic kidney disease, there's actually a bidirectional link. And we now have very strong evidence that if you go get your teeth cleaned and your gums cleaned, it actually can improve your glycemic control, your blood sugar levels. But the problem is not many people know about that. So it's important that we raise awareness in the community. and try and get them to see a dentist more frequently and more regularly.
Thank you. So, flipping to Matt. So, public health, something you're very passionate about. Talk about the unmet need, that what funding and research could do in public health.
Yeah, thanks. And probably following on a little bit from Ajesh, you know, we see in Australia dental disease being one of the most prevalent health conditions affecting Australians. You know, children by the age of 5 to 6, around 1 in 3 have dental caries by the age in their deciduous teeth. About 40% by the age of 12 to 14. It's the leading cause of preventable hospitalisations. There's a really strong social gradient, so we know that disadvantage is a really strong risk factor for dental disease across a range of different metrics for disadvantage. We've seen periodontal disease increasing in Australia over the last decade, and you know, when we talk about that oral systemic link, we're also seeing things like diabetes increasing, overweight and obesity increasing, and so the need for us to have a better understanding of some of these public health problems and the interlinks between oral health and systemic health. Oral cancers, again, you know, one of the leading cancers in Australia and increasing as well. So we've got this kind of burden of disease that's increasing. We've got this really significant disparity issue about who is greater risk of disease. We've got geographic disparities. We've got then sort of workforce problems that intersect on how we might try and tackle some of these problems at the coalface, but then we need to be thinking about how do we, from a public health point of view, how do we actually prevent some of these problems? What are we doing from a dental perspective? What are we doing in a multidisciplinary way to tackle some of the root causes of these problems? And so research is really important in underpinning some of that activity to say, you know, how do we go upstream and start tackling things like sugar consumption? What are we doing in the space of, you know, taxing sugary drinks or marketing to children in areas that will benefit us enormously in oral health, but will benefit the community more broadly in a general health perspective as well. So I think that this is a really important issue. And then I think one of our really big problems in oral health is that we actually don't really have anywhere near enough data to be able to tell us what the problems are, where the problems are, and how we might be able to fix them. So there's this massive gap in our research understanding in a public health setting, and part of that is because a lot of the funding goes into other areas that don't necessarily come to the public health side of things.
Thanks, Matt. Munira, you have been championing in research in academia for years. Can you explain to everybody why this is critical to have it at the grassroots in academia?
I think the research is fundamental to future-proof dentistry. So in universities, we are not just reading out textbooks to the students. We are teaching them how to use evidence-based practice to optimize their clinical applications. So with that, the students need to have a critical thinking process, which stems from the research. And universities are not just transferring knowledge. We create new knowledge, encourage innovation. So many of the research products, the materials that we use in dentistry, all the advances in the science and the medicine stems from university. So that's why the ecosystem of integrating research into teaching matters so much. So as a university academics, we also have the duty or in our role to maintain research and publications. Every publication needs large amount of research outcome to support. And this is one is to maintain our roles as academic, as publish or perish, and also to create this ecosystem that supports the students and the junior academics to grow. Because we have a duty to generate or maintain research environments like laboratories and provide funding and mentorship for the junior students and the junior academics. Maintaining this ecosystem really needs the funding to the research system. And I think coming back to the research, the academic excellence, it's not just generating or giving a good lecture, but also teaching the future dental students and the dental academics to have a critical, innovative the training process as well.
Thank you, everybody. So I want to get a little bit more personal. And you guys all had choices with your career. What made you personally pursue research? So was there a moment, was there a person? Why did you pursue research for the greater good? So I'm opening it to anybody. And I'm going to throw Matt in.
Why did you do the things that you do? That's a question I ask myself very, very often. I think, my view on things like this is that people tend to fall into the things that naturally fit them. And so I was working in the army. I joined the army as an undergraduate. I graduated. I moved up to Wagga, which is where I first met Hugo, who's sitting here somewhere, right in front of me, right in front of me, working in clinical practice, with a view that I would do my short time in the army that I had to do, and then go and work in private practice in regional Victoria, where I grew up. That was the plan, and plans never eventuate, and so. Where I was working, we were seeing a lot of army recruits coming through. Our job was to see army recruits. They were coming in from all over Australia. And I noticed this pattern between those who were coming from Queensland, where there was no water fluoridation, those who were coming from Sydney and Melbourne, where there was. And it was interesting enough that I thought, maybe there's a research paper in here somewhere so that some poor dental student in the future can cite Hopcraft et al. In 1990. And that was it. And so I collected the research, collected the data, published the research, and then it just kind of snowballed from there. It just went out of control. But what I found was that it was something that I really loved doing. And so I found my niche in dentistry, which was less about clinical practice, and clinical practice just slowly disappeared over sort of 15 years. So for me, it's about, I think, finding a problem, solving a problem, and putting my experience, expertise, whatever, to use in solving a problem to improve the oral health of a community rather than an individual that's sitting in front of me.
Beautiful. Thank you, Matt. Who else is brave enough?
I can. My background is general dentistry, and I have trained in the oral surgery. So I was happily doing my surgeries, and I got an unexpected opportunity to get a scholarship from the Australian government to come to Australia from remote area of China. So I am ethnically belong to the Kazakhstan population. So in our tradition, there's a very few girls actually go into the PhD level study. So I wanted to be the first female PhD representing Kazakhs in the world. So luckily I got the scholarship, and I had a great mentor, Professor Hans Zollner, sitting here. So he was my PhD supervisor. So I sort of accidentally got into research, but then it is like a Hotel California. You can't leave. So after my PhD, I went to the Cornell University in New York to get involved in the cardiovascular research, and coming back to Australia, working in the Victor Chang Cardiac Research Institute. So I found it amazing that kind of innovation and the creation that happens in the cardiovascular research and regenerative medicine, which I brought to the Sydney University, my laboratory, start to look at how orofacial muscles develop, and interestingly, they actually bud out from the heart, so they have a lot of similarity to the cardiac. So now looking at this area, and then I found that teaching with the research knowledge and then this passion and innovativeness to the students are much more effective than. So I'm sort of stuck in academia, and I'm really loving it as well. So now I can play a bigger role through the Australian Dental Research Foundation, and I hope the efforts from everybody could lead this foundation to a greater future.
Quick one, yeah. I think a common theme is accidentally falling into a thing. Same thing happened to me. After completing my dental and public health training and doing a PhD, I was completely lost. I didn't know what to do, and I started interacting with a lot of primary healthcare providers, nurses, midwives. And I kept on, this way back in 2008, asking why weren't we talking about oral health in the primary healthcare level? Why is it always the dentist's role? And that started, I guess, a conversation with a few champions. We started trying to get midwives at that point to talk about oral health. But at that point, you spoke to midwives, said, that's not what we do, right? And so it was a lot of challenges along the way. But we persevered, and slowly that movement started. And I think a couple of years ago, we have a national training program for midwives around oral health that has been rolled out. And a couple of years ago, I was at a large hospital here in Sydney. I was speaking to midwives and just asking them what they do about oral health. Do they talk to pregnant women? The majority of them were basically saying, no, we don't have time for it. It's a challenge. But there was one midwife there, was a new grad, and she said, I don't think twice about oral health. I always talk about oral health with pregnant women. And upon asking what happened, she said that she had been taught oral health in her undergraduate curriculum at our university here. And we had started implementing that about 10 years ago. So it was shocking to see a graduate in a room with you and saying, it's part of my DNA. I'm doing this now against what the norm was. So that's what gets me up every morning, because you can see real change happening.
Thank you. I had no idea. Deb. Again, another falling into opportunities or not. Basically, I had a fantastic time living in Canamble, which is out at Midwest, I suppose you would call it, of New South Wales. And I was working for the University of Sydney at the time. I'd been sponsored out by them. And ADA, New South Wales Health, Royal Flying Doctors, a whole group of people all got together and put together a rural placement program, which was a student-centred 2-week experience. Hans might remember this back from the 2000s. Hugely successful, and formed the basis of my PhD, which was all about dental education, mobilising the workforce and trying to improve the oral health of those living outside larger areas. And as a consequence of the research itself, several of those people who I still bump into 25 years later actually spent some time working in rural areas. They didn't all stay, which is fine, but they did go there based on the experience that they had. And I can remember my daughter saying to me when I got the PhD, it was a qualitative study of their student experience, and they were so excited, and they said, does that mean you get a pay rise, Mum? And I said, no, it means I keep my job, and if I'm really lucky, I might be able to go up to the next level. So to pull that together with Matt's comments, in order to progress in dentistry, in academia, one has to be a teacher. That's critical, obviously, but you have to also have research to have a career. And this is where we really struggle, because the dollars are not there compared to medicine, for example, and other areas. In dentistry, we are woefully underfunded. If you look at NH and MRC success rates, etc., we've had a special round this year. But that's why not-for-profits like the ADRF are so important. Because unless we, shout out to Zanab at the back as well, she's latest PhD success story from me. Unless we do get that funding and that buy-in from the profession, we're really, really going to struggle for an academic workforce. So it's wonderful that so many people have come along, and we really hope that you'll reach out to all of us and look for opportunities where we can work together, where we can continue to push the word and the value of research. It's a very dry subject, you say research, and it's like, yeah, whatever. But it can be exciting when you spend time with students in Canamble, I promise you.
Thank you. So we're going to stay on this point, and we're obviously here to raise funds and raise an awareness for the ADRF. So I'm going to stay with you, Deb, and I need you to explain to everybody here how the ADRF is funded, how much we have actually been able to use up until now, and what the future could look like if we did have that funding.
I might have to go to Hugo for exact numbers, and Hugo's sitting there thinking, oh God, don't do that, Deb. In terms of what we need, first of all, we need to increase awareness of research. The ADRF has been supporting research to the tune of millions of dollars for well over 20 years. And we're now moving into the stage where we're offering bigger grants to teams of junior academics to support their growth through the academic pathway, but also teams of collaborators, as I mentioned before, outside dentistry. And it's about increasing awareness of our profession and increasing the awareness of oral health in terms of general health, as Ajesh said. What can you do? You could give us the price of a cup of coffee. What is it now? $5? $6? Okay, what's that? $25. $25. Every little helps, and we all know that it's really hard these days to get money. There's a lot of competition for donations. We all get cold calls about giving money to this, that, and the other. But this is our profession. This is what we've all chosen to do, and we want to be good dentists, and we want our patients to be safe and to get the best possible care that they can get. So if we can't invest in our own profession, I think we're being very naive expecting people to invest in us from elsewhere. So even if you can only give a little bit, but give it on a regular basis, that's one option. We do have one very generous donor. I'm not sure that I should say the name, but this particular gentleman has literally kept ADRF afloat. I wish I could say his name, but I don't want to compromise his privacy. So things like, if you have any, well, I was going to say any intention of dying, but that's a bit odd. I just suddenly thought, no, that's not right. That's not right. Our profession. But we do well out of dentistry. Dentistry is very rewarding in so many ways, but it's also rewarding financially. So to leave a small bequest in your will for dental research, those types of things I think are just so important in terms of professionalism and being a team playing together.
And I'm going to put my hat on as a representative of the dental industry and the guys out here that make ADIA possible for you guys in the room. Hands up, hands in your pockets, please. We're one industry that we feed each other, and without the dental industry, without the dental profession, without research, nobody can progress. So for the dental industry in the room, it's critical for the future of your livelihoods that research exists. So the shout out isn't for just people that are willing to leave in their wills. Let's make this living donations. Let's make it industry donations and professional donations. My 2 cents. So, Matt, I would love for you to talk specifically about an ADRF grant that you received and what that meant for the research that came about.
Sure. Just onto So for those who are from AFL states, the Collingwood Football Club earlier this year caused some controversy by sending out to their older members a notice saying it would be great if you're not planning on dying, but if you wanted to include the Collingwood Football Club in your will. So it's not an unprecedented thought. They did get a little bit of blowback from some of their members.
I will as well.
Well, we're not even going to go into the oral Collingwood systemic link there. Like I mentioned before, my first foray into research was around water fluoridation, and I was fortunate enough to get a couple of grants from ADRF early on in my career to do further research in that area. So we did a number of studies of oral health of young adults and the links with water fluoridation. And most of the water fluoridation research in Australia and internationally has been done on children, not on adults. So it was, I'm going to talk myself up here, but I think it was a really important piece of research that added to our understanding of water fluoridation and has then been really beneficial for people who advocate in that Australian space, and particularly the Queensland sort of scenario through early 2000s leading up to 2008 when water fluoridation was pretty much widely switched on in Queensland, and is now still really important because with changes of government in Queensland, we're seeing local council after local council after local council switch off their water fluoridation. And without getting overtly political, what we're seeing happening in the USA is translating to what's happening here with water fluoridation. So from a public health perspective, having good quality research that demonstrates the benefit, the cost effectiveness, the public health benefit, the equity issues around water fluoridation is really important. And so I can see a little bit of where my research, where that funding from ADRF has helped that bit of research that has helped to underpin a really important public health program. But then I think the other part of it is that early research has then helped to train me to become a better researcher. And so the subsequent research that I've done that's had impact in other areas that might not have been directly funded by ADRF has certainly been influenced by the fact that I was able to start a career and have a career in research and develop some research skills. So I think sometimes we think about research impact in a narrow sense. Did this particular grant translate into an outcome that influenced a particular policy or changed something, developed a new material, a new way of doing practice that has an impact? And that's really, really important, and that's what we all sort of strive to do. But, to Munira's point before, we don't have a dental education workforce without well-trained dental academics who are well-versed in research. We don't train our future workforce to have the critical thinking skills to walk around this room and ask the right questions and understand the implications of new materials, new equipment, AI, how that's going to impact on practice. So the way that ADRF has helped shape generations of young researchers moving into academia or clinicians moving out into practice, specialists who have then gone on into specialist practice, I don't think you can underestimate that impact beyond the specific project that it was funded. I think that's really important too.
Thank you, Matt. So, Munira, let's talk about the cumulative effect of ADRF grants and what it's meant in early stage research in academia.
Okay. So I'm going to contradict you, Deb. The ADRF was built in 1973, so it's 50-odd years. And by the ADIA CEO, Mr. Colin Comey. And initially was all on donations from the dentists. So in 1996, ADRF become incorporated, and the main focus of funding was to dental students and early research career people in the dentistry. So it's over 2,000 grants have been awarded since then. So there's those small grants usually has $5,000 to $10,000. Those kind of small grants, I would say, that maintained lots of small laboratories across Australian universities, dental schools. Also encourage a lot of students to take up research related career and academic career. So I will name his name. The Professor Saso Ivanovsky in the Queensland Dental School. He's the Dean of Queensland Dental School. And he was saying that when he was a dental student, he received the ADRF grant, and that actually triggered his research interest, and he became now a leading dental academics in Australia. I'm more directly involved in the past 8-9 years with the ADRF, so in the research advisory committee. So we typically receive 50 to 120 applications per year, and only 10% of them get funded, but mainly funding the early career researchers. And we can see some great impact from those small pocket of fundings. For example, I got consent to talk about Associate Professor Tammy Yap. She is in Melbourne University Dental School, and she looks at this oral swirl. So you just squish your mouth and that kind of get the cellular debris to detect or predict oral pre-malignant lesions, transformation to malignancy. So she got a few small grants, and now her research is developed so much that recent years she got over $2 million funding from NHMRC and MRFF. So you can see the impact of the ADRF seed fund can result in a very great research like that, and then helps the prevention, early diagnosis and the prevention of the oral cancer. And we have a lot of this kind of examples. For my own research, as I said, I've been working in cardiology, and then I found there's a pool of stem cells in the tongue that's come from the heart, and then we are isolating those cells to differentiate into cardiomyocyte. So this one was stemmed from a seed fund some 10 years ago from the ADRF $10,000 fund, and it started this, made us discover this pool of cells, and then now it's going to patenting and commercialization in Sydney Uni. So as a dentist, I can actually regenerate a heart that whole cardiology field hasn't been able to achieve. So you can see how dental research funds can lead to something very unexpected.
Incredible. Thank you, Munira. Ajesh, you haven't received ADRF funds, so we've heard from Munira that 10% of applications are being approved. What do you believe the opportunity could be if we did have more funding? So for the industry as a whole, where do you see the greatest opportunity?
Thank you. I think I can't stress enough the importance of having small seed funding pockets, because it's a catch-22 situation, because if we want to change practice and improve patient care, we really need high-quality, large studies like trials to provide the best evidence. But to do those studies, we need large buckets of money, and that comes from bodies like the National Health and Medical Research Council. But they require you to have pilot data, good track record, and show proof of concept. And how do we do that? We need small pockets of funding to achieve that. So it's crucial that we have those small pockets of funding, because otherwise you can't start the journey, as we've all shared here. And if I reflect on my own journey, I mentioned that over the last 15 years, we've had this model of care where we've been training midwives to promote oral health among pregnant women. That program has then gone on and been scaled up across Australia and internationally, and was recognized by the World Health Organization as well. But it all started in 2008, when, and I know this value very well because New South Wales Health gave us $3,030 to start that project. So, it has to start somewhere, and that's where that, getting that funding to start the journey. And I'm glad that ADRF is going into that interdisciplinary area because, you're able to then leverage that and get funding from other disciplines as well.
And just to sort of highlight where Ajesh is going with this, because it is that catch-22, without a track record, without some pilot data, without an established team, it's impossible to get some of that large funding. And what we see in those large schemes, the NHMRC and MRFF, is that dentistry and oral health gets very little of that funding. So between 2017 to 2021, NHMRC handed out $6.6 billion of research funding to the top 75 diseases. Oral health got 15 million of that 6.6 billion, so 0.23%. And it's the most inequitable relative to the disease burden, the impact of that disease on health of those diseases, like by an order of magnitude. So you can see how oral health is not reflected in the broader funding, and it really reinforces, I think, the importance of establishing a really good base of this seed funding that ADRF does really, really well, and being able to expand that, because that's the thing that's going to really catapult, Tammy Yap and people like that to those bigger grants, and Munira to those bigger grants that actually then are the ones that are going to have the enormous impact.
Thank you. So we are talking about the gap in research, and I actually want to stay with you, Matt. So nothing's coming through Medicare. We're underfunded due to lack of funds within the dental industry. In your view, what are we missing out on? What does this gap actually mean?
Yeah, and I think there's probably a couple of different ways of tackling that question, but and it partly goes to priorities. So we're not seen as being an important area of health, and there's the whole silo kind of issue that dentistry sits separately, and the work that Ajesh is doing and trying to break down those silos, the multidisciplinary stuff, the impact of oral health on broader health is really important. I think it's reflected when we see that data on NHMRC and MRF funding, that it doesn't flow to dentistry because it's not seen as being an important issue. And that sort of reflects up to government. I think there's an argument around saying, well, if dentistry was included in Medicare, it changes the priority, it changes the focus of government, of funding organisations, to then start thinking, well, how do we focus more of our attention on prevention of these problems so that we reduce the burden of disease, we reduce the expenditure. And then I think where one of the really big gaps is, I said it before, is lack of data. So, one of the advantages that we see in so many other areas of health is that there's an abundance of data to be able to understand problems and to be able to then target programs accordingly. And we really miss out on that in dentistry. So I think really huge opportunities for us to think about how do we, regardless of the Medicare question or not, but how do we raise the profile of oral health? How do we make it much more visible as a problem? How do we highlight the research wins that we're getting and the activity that we're doing so that we get more research funding externally, and that a lot of that comes from some of the research that we do. And then I think a really big piece is around science communication. So how do we, as a profession, how does ADRF as an organisation, how do we promote the work that we're actually doing externally that then helps to solve some of these problems as well? And I think that's a really big issue for us.
Thank you. I'm going to hand to you, Deb. Can you talk to the gap between what we get as a dental industry compared to other health modalities?
Can you expand on?
So when you're looking at grants and when you can compare, and I don't know whether Hugo can add in here or Munira, what is the difference in the funding to dental compared to other health, to general health?
Tiny is the very short answer. It's tiny. And like so many other aspects of our profession, dentistry is not particularly sexy. It doesn't really hit the emotional buttons for politicians. We all know that from lobbying, Chris, particularly from an ADA perspective. Dentistry is kind of a bit over there. Also, I should say this as a personal opinion that I think for a very small profession that looks after very little bits of the body, we're not terribly united. There's lots of different silos within the profession, which means that we don't really optimise what we could achieve as a united profession. So Kim and Hugo, this is amazing that we can have this joint session today, because we are, as you said before, totally dependent on each other. Totally. We can't be dependent on the government, because everybody has an image of a dentist driving around in a Maserati, you know, with the wind going through his baldness. So you know, at the risk of doing it, as I said to you before, doing a Martin Luther King, we need to have a dream to work together and to work to support each other in keeping this profession alive and growing and vital. So that would be my personal plea.
Thank you. Ajesh, you have been successful in getting research grants. How does that look like when we do compete against other medical professions? Can you talk to that point?
Yeah, it's a challenge. We don't do well because, in funding, because we're competing with, as Deb said, other sexier areas like, cancer and chronic disease. And I think it stems from a number of reasons. First, from the funding body's point of view, they don't really see the link between oral health and broader health. They don't see the impact you could make. And I guess that also stems from the fact that research is still growing to show that causation. 3 years ago, we didn't know that cleaning your gums will improve glycemic control. We got that evidence through research. So number one, they don't see the broader impact. They don't see the cost effectiveness of it for health services, because it is all about that. And I think also because, as in dental research, there are very limited pockets of funding for pilot data, when people do put it up, sometimes it's not as competitive because we haven't had that track record to reach that level. And on top of that, the icing of the cake is we don't have targeted calls specifically for health research. In the history of NHMRC funding of 80 years, last year was the first time they ever had a targeted call, and they only funded 4 projects at the end of the day. So I think it is challenging, and it's about, I think, building that track record. But I think interdisciplinary, because you're able to then, within the constraints of the system, start getting pockets of funding from other disciplines as well. But really trying to convince the broader policymakers and I guess funding bodies that the mouth is part of the body.
Thank you. And so for me personally, we are in the innovation mode. So I have an AI startup outside of clinical. So I'm spending my time talking to venture capitalists. So different research, different funding, but the same problem. So in the world of venture capitalists, what I'm seeing right now is there is money going into hospitals. There's money going into GPs. And we rock up and we start talking about dental, and it's unknown. We are unsexy, have to say it. I agree, Deb. And we're not being talked about. We're not getting the funding in the VC world. So it's going across the board of all forms of innovation. So Munira, let's talk to the workforce and what this means when it impacts the students, the professions. What does this lack of funding mean to our workforce?
So I can make a comparison between the cardiology funding and dentistry funding, because I had a privilege to work in Cornell University as well as Victor Chang Cardiac Research Institute, one of the most privileged funded institute in Australia. And the comparison is stark. It's shocking in a sense. So, for example, for projects that costs $1 million, that cardiology gets $1 million, as equivalent impactful project in dentistry will get $50,000. So you can see the comparison there. And I've been lucky enough to have my cardiology, the collaborators, to do some high-cost, high-technical aspects of my project. So that is actually helping me to propel. But not everybody is that have that kind of connection. So the research funding is not just for experiments. So we are just funding the experiments, and it's also about the workforce building. In the cardiology, there's a strong pipeline of building, like a training PhD students, postdoctoral, and the research fellows, the senior research scientists, and all the technical support people. So they have this seasoned experienced research workforce to help to create high quality data that makes them quite visible in the whole the healthcare, right? In dentistry, we rely on the PhD students, or the honor students. Sometimes they're very cheap labor, easily, but it's also very high turnover as well. We love to train PhD students, all of us do. But once they graduate, they will move to somewhere that's with pay. We don't have funding to pay our research workforce, so we have this constant training, which, in a sense, impacts the research quality, as well as workload for the academics. We are just the training and the turnover, and then send them out. So we don't have this accumulation of a research workforce. So large funding, for $1 million, I can employ postdocs, but for the $50,000, I can have honor students to do the experiment. Or we can go in and feed my cells and do PCR, things like that. So all of us do. So it is a stock, comparison in a sense. Yeah.
Can I just sort of going on from that and thinking about impact from a different perspective? We've talked about how low the success rates are for ADRF grants, sort of 10%. It's significantly lower in oral health for the large grants like NH&MRC and MRFF. And the impact that it has on the researchers, it's demoralising to spend hours and weeks of your time preparing grants, knowing that your chances of success are almost zero. And, the stability, the sustainability of your team kind of depends on that as well. And so there is a bit about, the impact on the workforce of having an ecosystem that is just not well set up to actually sustain the work that we're trying to do. So anything that helps that process along and gives a little bit more stability, a little bit more funding at the seed level, it's going to make the chance of success at the bigger level a little bit more, is actually, really important for the health and well-being of the people who are doing the research as well.
Thank you, Matt. Okay, so a bit of audience participation. We want to know who's in the room. Okay, I don't need names. We just need credit cards. That is a joke. So who here is in research at the moment? Show of hands, please. Great, thank you. Who here is working in clinical? Amazing, thank you, welcome. Dental industry? Great. And students? No, there's a few. And who have I missed? Did I get everybody? Okay, so we're going to speed things up, and I want one clear sentence from you all about why the people in the room need to care about funding and support the ADRF. Matt.
You don't always have to start with me. Yeah. One sentence. No professors, no profession. I think without an academic workforce, our profession is not going to progress forward, and we need to be funding that pipeline of people coming through to generate an academic workforce to train the future dental and oral health workforce. So without that, we cease to exist.
Amazing. No, I like that longish sentence. Go. Who's next?
Okay, so future of dentistry really is in our hands, all right? So the future of dentistry is evolving. We have a more of a aging population riddled with chronic diseases, and for that we cannot work in silo. We have to collaborate. We have to look at stem cell and regenerative medicine, AI, robotics, all that. So we need a collaboration. Everybody's in it to propel the dental profession. Without research, without innovation, maybe robotics will replace us. We become irrelevant for future. I think to stay in the forefront of the health community, everybody needs to involve. Everybody needs to care. Otherwise, we will not exist as a profession.
Thank you.
I'm going to weave two sentences into one, all right?
Only two.
We are in a unique position now where we can try and improve the oral health literacy of your community about the oral systemic link, so we can get more patients to come in to the dental practices, right, and try and improve their oral health care. You know, if you tell someone with type 2 diabetes, if you get your teeth cleaned, they may go down, it improves your glycemic control. They may walk down to their private dentist and get the teeth cleaned. But we're also in a very unique opportunity, and that's where research is showing us that the dental workforce can play a greater role in broader health. Because of the unique opportunity we're in terms of seeing patients regularly. We have, for example, in New South Wales Health, public oral health practitioners doing height and weight screening to address childhood obesity. In Sydney Dental Hospital, they're doing domestic violence screening and working with social workers. In the US, there are insurance companies that are working with private practices and saying, if you offer a heart wellness check, blood pressure screening, you'd get more incentives there. So they've also got policies where if you get diagnosed with a chronic disease, you get free dental treatment. So there are ways in which we can change the dental industry to make it more integrated, bring in more patients into the chair, but also get you to do a bit more variety and not just the mouth and look at broader health issues.
Thank you. And Deb?
I'd like to take 10 sentences and sorry.
Keeper says no.
A bit like the computer. I would like to say let's cooperate and collaborate to make dental research sexy.
Amazing. Thank you. So the final question, we're going to do some blue sky thinking here, and we're going to talk about the future of dentistry. Where do you think we could land? What could the future actually bring? In one sentence.
I'll start if you like. I'd love to see us all working together on a consistent basis to further our profession, not just from a research perspective, but research being core to the development of everything that we do, literally everything that we do. And if we are not... So my vision is everyone skipping in a meadow holding hands.
Beautiful.
How's
Thank
that?
You.
That's very true.
I think for me, big data, because we're living in a world where we've got so much information about people, but it's not connected. And so it tackles the silo problem and the interdisciplinary stuff. How do we actually tap into the data that exists out there and use that in a way that's most effectively going to drive forward improvements in health, oral health, improvements in general health? And if we can solve that problem, and there's an AI bit to that, there's a data piece in there, and then a huge research piece that sits around it. I think that's the way that we're really going to tackle a lot of the problems that we're seeing.
Okay, dentists in the past was called Mr., right? So not doctor. We tried 100 years to evolve into doctors, but the broader medical community still sees us as Mr. So how do we really be doctors and integrate into entire health system? Is that through innovation, through research, through education, and to really play a good role in the overall healthcare system, improve human longevity and a healthy life.
For me, I think it's making oral health everyone's business, and having the broader health workforce, medical, nursing, allied health, as our allies, and work with us to address the burden of oral disease.
Do we have time for questions?
We have 5 minutes.
Okay. Okay, so I'm going to open it up to the floor, and I probably have time for 2 questions. Does anybody have any questions? Looking at you, John.
Yeah, I'd just like to ask the panel, what do they see as the major areas necessary for research to take the profession to the next stage? You've talked a lot about the importance of research, but are there certain areas of research that you're seeing as absolutely crucial, absolutely critical?
I can talk to that a little bit because in the multidisciplinary collaboration is probably one of the key points. So in the past, the ADRF has funded individual early career researchers. And in recent 2 years, we are putting out the collaborative research grants. For say, in the past, we may have funded 5 students individually for small projects. Now we're encouraging 5 of them to collaborate and make a more impactful project. So that includes the multidisciplinary and also the established this, inter-school, national, international collaborations, multidisciplinary collaborations. So that's one of the key points that we are going forward.
I was going to say, I think another area that we need to be really thinking about, and this is completely at odds of what we've been talking about to date, is the whole issue of AI and the influence of artificial intelligence, whether generated or whatever, on patient care. If we haven't got a profession that's research literate and able to analyse outcomes of ChatGPT reports, and I have seen examples, then how are we ever going to know what's real, and how are we really going to know what's safe for our patients? Patient safety is really key to all of this, and it's great that we can provide, have research around provision of care, but it has to be safe care, and it has to be appropriately informed care.
I'm going to follow on from that. And double down on my, big data kind of question. We've got 27,000 dental practitioners out there treating millions of patients a year, but we don't really know the impact of that. Are we actually improving anyone's health? We don't really know. And so when we get back to that really fundamental question of improving oral health, patient safety, I think a really big research opportunity and a really big research gap is what impact are we having, and how do we better understand whether what we're doing is improving people's health or not, and then how do we perhaps reorient our workforce, reorient our treatment philosophies, reorient some of the other things that we do so that we actually know that we're having an impact. And maybe that then helps with some of those other things about raising the priority of oral health and getting people to understand where oral health and the work that we do is really important.
And just adding to that, I think whatever we do is better than what's happening now. We're not addressing oral health disease. It's still a big issue. So what we need to focus on is obviously looking at the evidence and looking at more sustainable and cost-effective. Cost-effectiveness is key because I don't think dentistry is going to be part of Medicare, may or may not, but so we got to work within what we have, and we have to make it cost-effective and sustainable.
One more question?
But also I'll use the microphone so others can hear me. Hello, good morning everyone. My name is Vesna Miletic. I'm professor at Sydney Dental School and also head of restorative dentistry. I'd like to thank all the speakers for your really insightful comments. There's nothing I disagree with. I would just like to make an observation and make a suggestion, actually not a question, if I may. So the thing about collaboration and working together, I couldn't agree more, Deb. But also we need to think about what gets awarded. And to Munira's point, individual prizes, and there is a strong culture in Australia to award individualism, to promote individualism and star researchers. And this doesn't help collaborations. And what gets rewarded gets repeated. And what gets repeated sets the field. And this is how we get silos. So I think what ADRF is doing to promote collaborative projects is absolutely spot on. And I would encourage you to continue to do that. Actually, if you can use the platform, use the influence with industry to set up more of these collaborative awards and to try to set the tone to change the culture. So, thank you.
Yeah. Thank you, Vesna. Yeah, that's why I think the industry collaboration is really important as well. Also getting, as Matt said, we have a huge database in the private practices. And if we can get all the dentists involved, we can amplify the impact of oral health so much, exponentially. So the collaboration is the key here, I think.
I know we're really short of time. One of the things that happens when you have sessions like this is that we all sit here and we all talk about it. We all say, yay, yay, let's do it. Let's make it sexy. And then, next ADX, we'll do it again. So if anybody has got any interest whatsoever in learning more about the ADRF or ways of communicating with people who are involved with ADRF, if you can talk to one of us and share your contact details. Again, we need to get our presence more visible. We are addressing that hopefully slowly, but with your help we may be able to accelerate that. So that would be a plea from the panel, I think.
So rounding this off, I think we all agree that the opportunity for research is something that we should all care about. We've heard how drastically underfunded we are as an industry. We're hearing that we're not getting, or getting very little externally, not what we should be getting. So I have a number of asks. So please put your hands in your pockets. If you can donate, please do. Please spread the word. If you are the dental industry, please tell the people on the floor that did not make it in. And so that the next event we would like to be full to the rafters. If you are a clinician, please talk to your peers, tell them what the opportunity is for us all. On behalf of us all, thank you so much for putting aside time today. Ajesh, Munira, Matt, Deb, thank you for your expertise and knowledge. And I look forward to seeing everybody at the next event. Thank you.
I'm going to pump Carolyn up here very, very briefly. She's been amazing, absolutely amazing. Thanks, Carolyn.